Sometimes you can't even tell if they are anxious or depressed unless there is loss of function, like really severe. But sometimes they don't even know if what they're feeling is anxiety or not. And they tell you, I don't know what anxiety is, I'm good.
Pedia Pain Focus.
You're listening to Pedia Pain Focus, brought to you by Proactive Pain Solutions. Pedia Pain Focus highlights pediatric pain information and provides tools and resources for all healthcare professionals taking care of children dealing with pain. Here's your host, Dr. Anjana Kundu.
You're listening to Pedia Pain Focus, episode number 91. And today we're discussing how pain and mental health and psychology are so closely related, how they influence the prognosis and outcomes in each of these areas. So stay tuned. Hello there, folks. Welcome back to Pedia Pain Focus. And it has been a bit of a hiatus over here. Well, my professional life has been in a bit of a transition, and I will be filling you in on these changes that have occurred in the past year or so in my life very soon. However, I know you are excited to hear another episodes, and here I am with some phenomenal speakers coming to you over the next few weeks. And first in these series, my dears, is Dr. Mirabelle Mattar. Dr. Mattar is a child and adolescent psychiatrist. She's also the medical co-director of Judge Bruce M. and Cynthia M. Celia Integrated Care Unit at the Hasbro Children's Hospital. She's an assistant professor of psychiatry and human behavior, and this is at the Warren Alpert Medical School of Brown University. Dr. Mattar originally grew up in Lebanon, and that's where she did her medical schooling from. She also completed her residencies in internal medicine and psychiatry in Lebanon as well. Subsequently, she came to the United States and pursued a residency in general psychiatry at the Upstate University Hospital in Syracuse, and then she furthered her training with a fellowship in child and adolescent psychiatry at Upstate University Hospital and Hutchings Psychiatric Center as well. So Dr. Mattar is a board-certified physician in psychiatry and child and adolescent psychiatry, as well as neurology. She treats patients with coexisting emotional and physical disorders with a large multidisciplinary team at the Hasbro Children's Hospital. She believes in the power of involving families in the treatment and recovery of their child, along with engaging them in group therapy, individual therapy, and, as and when needed, medication management, of course. And her integrated approach to both mental health as well as physical health, i.e. pain disorders, is very evident from this interview, as you will see how effortlessly she helps us identify this relationship and interplay between chronic pain, acute pain even, but just in general pain and mental health disorders. And not just that, she also helps us recognize and gives us tools to effectively evaluate the roles that a child's social environment, their relationship, their family, and even their interpersonal relationships play into their pain propagation as well as pain outcomes. One of the concepts that she talks about, and I'm just going to tease it without giving you a lot more around it, is related to naming your emotion. And then she talks about how naming that emotion is a key factor in how their mental health as well as their physical health are impacted, and what that does and how that plays a role in the therapeutic milieu. We also discuss the role of trauma and PTSD when it comes to pain. We talk about whether there is utility for creating a distinction between real versus not real pain. And finally, we also talk about predictive factors that predispose one to developing pain, especially as they correlate to their mental health and psychological predispositions. So folks, I'm super excited and I want to bring Dr. Mattar on so that you can enjoy listening to her just as much as I enjoyed interviewing her for this podcast. So here she is. Dr. Mattar, welcome to Pediatric Pain Focus. It's such a pleasure to have you here. I am so thrilled. We're finally talking about a topic that I know is so important and that all of my audience would love to hear more about. And I'm so delighted that you get to be the person that gets to share this expertise with them. So welcome.
Thank you. Thanks for having me.
Dr. Mattar, can you tell the audience a little bit about your background and how did you become interested in this interplay of mental health and pediatric pain?
Yeah, so I did my med school in Lebanon, and while I was applying to residency here, I wanted to do something and continue my training. So I had a year of internal medicine in Lebanon. And this is my interest in internal medicine grew as well as psychiatry. And I felt that maybe later, after I'm done with psychiatry and child psych fellowship, which I was not very sure about then, I would want to go into the CL world or psychosomatics where there will be that interplay. I think I answered your question a bit of a long way, but I think that that extra year of training gave me more interest in that world. And it's also very interesting how in the world where you think you're not seeing someone who has a psychiatric illness, you actually do. So it was really interesting to me to see both and see how we can provide the treatment for both.
So I know one thing you said is that it was interesting to see that where we don't expect it, you see this. Were there any other unexpected findings you saw with children with chronic pain and with psychiatric illnesses that surprised you, that you didn't anticipate or were just surprising to find?
I think what I've seen in the last couple of years of working with kids with chronic pain as well as depression or anxiety is that we're noticing also more of a propensity for disordered eating. And that was something that was surprising to me, but it seemed like there was an interplay there between feeling very sick, feeling in pain, not being able to go to school, losing function, as well as having abdominal pain. So even if the pain is somewhere else, there's sometimes also abdominal pain. And then that could be related to not eating, losing weight. And that was surprising initially, but then I started seeing it more often. So yeah, I think that is one thing I can share right now.
Right. That's fascinating. And like you said, you don't really think about it in that way. Of course, we want to know how they're eating, what they're eating, because food itself has impact on pain and even mood. We're seeing this whole big area of research and clinical implications from the gut-brain axis and how they're all correlated. But even then, sometimes we don't make that connection about disordered eating or eating disorders and chronic pain. I think that's such a great point that you make. And I think an important one for us, anybody who's taking care of these children, to at least consider. We don't need to be experts in evaluating and managing that, but just being aware, at least we can get them the right help. Thank you for sharing that.
Sure thing.
So that's one area that was a surprise finding for you and for most of us, I'm sure, on this podcast that we're hearing, including me. But since we're talking about some of the things that are so important to know, can sometimes we can be completely unaware of them and they can be a surprise. But then there are certain things that we know for sure that are important and that are relevant and really crucial for us to understand and know. So would you take some time to talk about why and how is it important to understand this interplay, this really important intersection of mental health disorders or even mental health impairments, plus the chronic pain in children?
Yeah, I think the concept of chronic pain and mental health is complicated and complex. And I think especially in family therapy, because our program and our treatment is really based a lot in family therapy.
Right.
Parents sometimes wonder, are we causing this? Are we guilty of this? Did we do something wrong? What's going on?
Right.
They can mention a few factors where they noticed that because they're so nice and they care about their kids, they did enable the illness in a way by providing the kid with everything. Instead of the kid needing to go to the bathroom, the parents started taking them to the bathroom, etc.
Right.
And we try to explain as much as we can that this illness has a role in the family and that we're not blaming anyone. It's really hard to tell if the anxiety or depression, if they are existent and obvious already, if they caused the pain that was maybe caused by an injury to last longer and to become more chronic in nature? Or is it a pain that started, whether it was from an injury or not, and continued to the point of causing depression and anxiety because of the loss of function? And this is where it's really hard to tell because sometimes it's both and sometimes you can't tell. But the most important part that I would want everyone to know about is that being able to label your feelings, naming your emotions helps a lot with decreasing anxiety and depression as well as pain. So that's one thing that people can, if they can practice it, if they can go to therapy and do more of that, that would be great. Because a big part of why pain continues, as well as if we're mentioning conversion disorder or FND, functional neurological disorder, is based in something we call alexithymia, which is the inability to recognize the feeling you're feeling. And it turns into a physical, that's, I think, is part of why it was called conversion, right? It turns into a physical manifestation of that same illness.
Right.
So one thing is to know how to label your emotions. So that would be one part of the treatment. And the other part is to work on regaining function, even or despite of your feelings. So we do know that even if you are in chronic pain, you are able to do things, of course, gradually and with time and with the supports, with rehab, PT, OT, whoever you need with you, and alongside family therapy. And we encourage parents and kids to go through that, even though it's hard, even though it feels disheartening, it feels maybe inhumane, whatever you want to call it. But that's the path to getting better. And I like to make the analogy of, because when you talk about psychiatric illness or something that is not very tangible, sometimes it's like subjective experiences of pain or of mood, etc. There could be some questions of, why are you doing this to my kid? Can't you believe him or her? Why are you allowing them to go through that much pain when they're saying they can't do it? The answer is, it is hard. It is going to sound terrible at times. And we want the kid to still do it. So if a kid is using a wheelchair, we encourage them to start moving toward a cane. And then from a cane to nothing or support of the wall. We try to move forward despite the pain. And we're hoping that, and we've seen that the more you function, the better the anxiety gets, of course, with time. But there's a worsening at the beginning. And the analogy that I make is appendectomy, or if you have an appendicitis, it's really invasive. It's really terrible if you look at it. Surgeons are actually opening the abdomen, going in. Like if you think about it, it's pretty invasive, aggressive.
Right.
And this is the only way of doing it to help the kids not have whole sepsis and infection of the abdomen. So you have to make an intervention that maybe does not look that great. And at the same time, this is the way to recovery.
Right. That is such a great point. Well, you made some amazing points and really important ones. And I love the fact that, especially when you talked about they co-occur. It's really not that important. I was actually going to ask you is like, there's this feeling of chicken or the egg. So what I heard you say is it's really not important who's first, who came next, or the fact is that these two coexist a lot and that it is important for us to recognize that and then move on to how are we going to help these patients get better. So I love that. And basically what I heard you say is it is important to acknowledge and address both of these pieces simultaneously and address elements of both of them simultaneously and artfully. And again, talking about both, especially with pediatrics, as everybody who practices in pediatric arena knows, both also applies to the family and the child. So we're always addressing issues with both of those, and especially for pain and mental health, as you said, it's the factors occurring between both the parents and children that have impact on the child's pain and their mental health. So it's so important to address the family as a unit and the child's issues themselves. So I just love this conversation. I'm so excited to be continuing this. So tell me, do all children, and I'm going to come back to the conversion conversation, which was, I don't want to gloss over that. That's really important. And we're going to talk a little bit more about it because I want to get your expertise on that. But before that, I just want to talk about some of the more basic things, like, do all children have mental health issues when they have chronic pain, or do all children with chronic pain end up having mental health issues? Like, how much of role do each one of these play in affecting what happens?
I think there are factors that put you at higher risk of developing chronic pain. I already spoke about the alexithymia, and that could be related sometimes to the verbal IQ also. The other part is that kids who are premature, kids who have ADHD, kids who have anxiety could be at higher risk of these illnesses just by the mere fact that they already have a brain disorder or brain immaturity, and they need more support in developing those skills. The other part is that it's really hard to tell, as I said before, which one came first, right? And I think because we're talking about inability or difficulty in labeling emotions, sometimes this happens in a family who has difficulty labeling emotions. So if a kid is not seeing someone model it for them, we are not blaming anyone, but sometimes there are cultures that are like that. So if someone is not modeling this for them, it can be really hard. So if someone has already a lack or difficulty in expressing their emotions specifically, what I'm talking about is not saying, I feel like I'm not good enough, for example, because that is not really a feeling. It's more of a thought. So you want the emotion there. Is it shame? Is it anxiety? And with that, you would go deeper. Is it contentment, feeling guilty? Is it feeling embarrassed? What is it exactly that you're feeling, not the thought of it? So this is where sometimes psychiatrists and therapists are annoying because they're like, this is a thought, let's go deeper. But anyway, so to come back to the talk, if someone is having difficulty expressing their emotions, sometimes you can't even tell if they are anxious or depressed unless there is loss of function, like really severe. But sometimes they don't even know if what they're feeling is anxiety or not. And they tell you, I don't know what anxiety is, I'm good. And then you start asking, do you worry a lot? Yeah, maybe. And then you go further. What do you think of this and that? And then you start noticing that there's, for example, a lot of perfectionism, which up until that point was seen as a very positive thing. And it can be. At the same time, that could be driven by a lot of anxiety. So I think that going deeper in the layers is really important. And we don't want to over-label people with disorders. That's not the goal. The goal is to treat them and provide them with a holistic approach, whether it's with integrative therapies, psychotherapy, rehab, all of that.
You kind of answered my next question about how does a clinician tease some of these things out and how do you know? So you've given us some really good things to think about, pointers to think about, and sort of just go deeper into what they're saying and look behind not just the words they're saying, but just sort of where that's coming from and what that might be indicating. And just because they've said, no, I'm not anxious, that shouldn't be the end of evaluating that. Are there particular mental health diagnoses that predispose children to developing chronic pain? And same and vice versa too. Are there chronic pain that is more associated with certain kind of mental health disorders that you see?
I think I mentioned already that the prematurity causing ADHD, autism, making parts of the brain not function as well as we would like them to, could place someone at higher risk of both.
Right.
And whether it's in a direct way or indirect way, whether it's through difficulties at school and social skills that are lacking, that cause bullying, that cause more anxiety and more isolation. So, there are different ways and different pathways. I would say that kids who are already on the anxious side and depressed side are at higher risk of developing chronic pain. Yes. I'm not sure that these are very big. Yeah, of course, these are very big umbrellas. Trauma, of course, can be related to it. At the same time, I think sometimes we overestimate it by saying that everyone who has FND, let's say, has a history of trauma.
Right.
It doesn't have to be.
Yeah.
And I think we sometimes want to go there just to see the one trigger, especially with the DSM-4. There used to be, I think, part of it that said it's usually caused by an incident. And when we sat for our boards, we were waiting for that thing. There was an accident and then they lost the ability to walk. But I mean, that can happen, of course. And at the same time, sometimes it's chronic. And trauma now is also, we see it more of an umbrella because sometimes you look at it as only sexual trauma, physical trauma, for example. But we know, especially in kids, that witnessing domestic violence, being medically neglected, not receiving enough food when you're young.
Right.
Like even things that are not necessarily done to you can have caused.
So the ACEs, right?
Yeah.
Yeah.
Of course.
So witnessing some of these, which are termed as sort of the adverse childhood events, right? It doesn't even have to be directly to you. Wow. Yes. And how big a role does PTSD play in? I know in adults, that's a major sort of contributor to chronic pain development and propagation, and even determines the outcomes of your treatment as well. But is that a significant factor in children as well?
Yeah, I would say so. And I think that we sometimes overestimate how much it needs to be PTSD, but it actually does not need to be PTSD.
Right.
But of course, complex experiences of trauma, even if you're not developing all of the symptoms of PTSD, you don't have nightmares, you don't have the flashbacks, etc., you can be at higher risk of developing physical symptoms.
So, as you said, it can be really hard to tease out, and especially people that are not trained specifically in mental health disorders, psychiatrists, psychologists. So for most of the clinicians that encounter these patients with pain issues, it can certainly be challenging, right? And you've given us some good pointers, what we can at least recognize. But when is it appropriate to think that we need to make a referral for even further evaluation or treatment for a patient who comes to us as clinicians for primarily pain issues, but also needs mental health services, or at least we suspect that they need, which seems like is a pretty good guess that most of them will need some assistance. When is it appropriate to invoke someone like you?
I would say all the time. But that's ideally.
Yeah.
And it doesn't have to be that we will play the major role or very big role.
Yeah.
At the same time, I think psychoeducation or education around pain and chronic pain is very important. And if it's done with multidisciplinary team, we always talk about that. But really, if you're doing it with different pieces of the treatment, different members of the treatment team, that comes with more strength and with one message of we all know that you're suffering. We all know that this has been going on for so long. There are a lot of ways to treat this, and these are the ways to treat them, X, Y, or Z. I think now the answer was referred all the time. And at the same time, we need to acknowledge that there are not enough child psychiatrists.
Right.
And we do not exist everywhere also, unfortunately. So I think referrals to primary care physicians, pediatricians, and nowadays there are more integrated care clinics that have behavioral health specialists in them, not necessarily psychiatrists, but, psychologists, social workers, and they can help a lot. So I think a referral to at least the pediatrician and to their team would be great. I also would include the school in that. I would want the system and the team to be really multidisciplinary and see who's going to help with what. And I think that when you miss out on part of the treatment, whether it's because it's not available or because the patient is against it, you're missing out on something. So when the patients are saying, I don't want to see a psychiatrist, I don't have anything that they can help me with, I think I understand where they're coming from, because from where they are looking at it, I have a physical symptom. Why are you referring me to a psychiatrist?
Right.
At the same time, the physical symptom itself can be due and can cause illnesses and disorders and loss of function, if we don't want to label it as anything, which by itself can be treated with psychotherapy.
So basically what you're saying is in multidisciplinary team, always that can address the psychological impacts as well as the impairments that come along with the chronic pain manifestations. But specifically, when should we refer them to a psychiatrist? As you said, there are very few of you. And I'm sure there are at certain points that it is definitely an important factor in their management. So when is that? When is it appropriate to specifically refer to a psychiatrist?
Yeah, if we're talking more about med management, I mean, I know that psychiatrists do some therapy too, and we can talk more about that. But if we're talking more about med management, I would say that in cases who are patients who have been struggling for a while, who seem to really be anxious, to very depressed with suicidal thoughts, then if we're talking about lack of safety or questions of safety, then they need an admission. At the same time, those would be the patients who would benefit. Also, if this is a patient who has an addiction problem, if this is a patient who has ADHD that needs to be treated, and sometimes the pediatricians start with the treatment, and if they're not seeing benefit or they're seeing side effects, then that would be a good time to refer to a psychiatrist. Ideally, again, it would be great to see everyone. But I think that if we can all share that same assessment in a way of like trying to figure out if the patient, and not just the patient, but also the family, if they're all struggling, I would refer to a family therapist. There are a lot of psychiatrists who do family therapy. So I think to answer your question more practically, when the patient is suffering for a long time, the case is very severe, you're noticing that there is not a lot of improvement with the usual treatments.
Great. And that basically answers one of my other questions that I was thinking about is often we start medications with multiple, especially in pain management, that will have multiple benefits. That's the ideal goal, is to try to get multiple benefits from one agent, one intervention. So we will often start with like tricyclic antidepressants or anti-anxiety or the SNRIs. And basically you've just helped answer when is it okay for someone that's just dealing with primarily with their pain issues versus when we should absolutely invoke your expertise. So thank you so much for that. So coming back to what you had mentioned earlier, and as you know, you may know, I'm sure you do, that one of the most feared and thus occasionally also misused diagnoses by people that are not psychiatrists is conversion disorder, especially amongst the chronic pain patients, right? With children. So how can a clinician that's not a psychiatrist, someone like me and a lot of my audience, how can we tease that out, or can we? And even more importantly, how do we best treat a patient with pain issues and suspected conversion disorder? What do we do for them?
Yeah, I think to differentiate them, basically the functional neurological disorder, or formerly known as conversion, is more related to neurological deficits or neurological symptoms that you're having, excluding pain and headaches. So in general, if you're talking about non-epileptic seizures or about loss of function of a leg or an arm or dysarthria or anything like that, you're talking more about FND. When you're talking about pain or chronic pain, you're talking more about, we label it as somatic symptom disorder with predominant pain. This being said, the treatment is the same, really. It's more about regaining function, about removing the accommodations, because that is part of also regaining function. It's family therapy, it's physical therapy, it's occupational therapy, it's speech therapy if we're talking about FND, because sometimes they have problems with stuff, or even with swallowing or anything like that. So speech pathologists can help us with it. Of course, having pediatrics on board is great because they can also help with making sure that everything was looked at, that the most common illnesses were excluded. And this is where the interplay is really important also, with not over-medicalizing, trying not to look for every rare illness that could exist. Because the more you look, the more you're going to find things that we call incidentalomas, things that are there, that then most of the time you don't need to do anything about. And then you fall into that whole spiral of, what do I do with this? It's unrelated to the current presentation. We know anatomically that this is completely unrelated. So what do we do with it? Right. And I think that not just with that, and not just with talking about the expenses and like putting the financial part on the side, it's a lot of stress to the family to keep looking more and more, even though they think that the more they look, the more they're going to be a relief because there will be one reason. The answer is the current interventions that we're doing will help anyway, even if there's something else going on. And we did look for everything that we should look for. So I think there is health and there's a therapeutic benefit from setting a limit and saying this is it, not in a negative way, of course not, but to tell the parents, because we are the experts. They know their kids, but we know the illnesses. So we know that this is how it presents. There are different inconsistencies. There are different things that tell us more that this is more psychosomatic. And it doesn't mean it's conscious at all. At the same time, it means that this is where the medical testing and all of the tests and lab work and EEGs and all of that need to stop. And sometimes these interventions or these procedures can help us diagnose these illnesses, of course, such as with an EEG that is negative during a non-epileptic seizure. That can help us. That's the gold standard, actually, to say this is a non-epileptic seizure.
Right. That's fantastic. That was such a beautiful explanation and such clarity in how we can address these patients. So talking about this, there's another issue that comes up. Obviously, it's not that common, but we've occasionally also encountered the Munchausen by proxy sometimes, right? And occasionally that occurs. And I certainly am not qualified to label it that way, but sometimes you're bordering on a parent's behavior that makes you think that it's getting to that point of ridiculousness. Well, I think it's ridiculousness. Perhaps that's a little bit harsh to use. But how do we best work with children with chronic pain issues? They're clearly coming to you as chronic pain issues, but you also suspect that there's some over-exaggeration or, if not, frankly, Munchausen by proxy going on from the parent's perspective. What do we do in those situations?
Yeah, I think these are really tough places to be. And thankfully, we don't see them too often. And it's really important to keep that in mind and to keep an eye for it, because this is a form of abuse. And we don't want the kid to be abused and have medical abuse of a kid by over testing them and having them at the hospital for so long, etc. I think that we assume usually at the beginning that what's going on is all real. And now there's going to be a lot of questions of what do you mean by real? Pain is always real. But if we're talking about by proxy, then I don't know if the parent is causing this or reporting misinformation. So this is where the question, I hope I answered that question of real.
Yes.
But the question of Munchausen by proxy, it's really important to try to understand the beliefs of the families and their relationships. Relationships can sometimes be enmeshed, and pain can cause it to be even more enmeshed. And that's why it's really important to see where is this family lying in that spectrum of enmeshment or not, and what is their belief about this pain. The healthier the family is, or the healthier they get, hopefully, it will be where they can see the pros and cons of a symptom or an illness, meaning that they can explore the mixed feelings about their kid having an illness, and whether it's, yeah, I really hate it, my kid cannot go to school, this is terrible, I really don't like it, I don't like to see them suffering. And them being ill also helped me stay at home more. I was able to spend more time with them. I was able to actually take care of the house, acknowledging the mixed feelings that happen with everything in life. We all have mixed feelings about everything.
Yes.
So I think the healthier you can see that, the healthier you get, the more you can see the mixed feelings, the less enmeshed the families are. This is a long answer to tell you that the more you're seeing that the beliefs are stuck in the kid is ill, there's nothing that's going to fix it, the more you're there and the more enmeshed they are, the more you're looking for what's going on there. Where is the spectrum of conscious versus unconscious? And is the parent playing a role to make it worse or better? Is it with good intentions, bad intentions? And it gets tough. And most parents, even with Munchausen by proxy, have their own illnesses. And most parents who are playing a role in Munchausen by proxy have their own illnesses and their own upbringing and their own beliefs and about their own family that they grew up in. Even though it is abuse, I can see also how it can be misdiagnosed or underdiagnosed or not seen as well, because the intention could be good. At the same time, it doesn't mean that it's not abuse. So this is a long way to tell you that sometimes you need help from someone else outside the team too. And
Right.
whether it's a state agency or another medical professional who can come and take a look, I always
Right.
recommend second opinions or third opinions if
Right.
you're really getting confused.
Right.
Humility is great. You need to recognize that
Yes.
you have your own feelings, you have your own thoughts, and
Yeah.
maybe sometimes it's clouding your judgment. So ask for someone else to come take a look, think more, talk to the parents. And we have, fortunately, but I'm not sure that this exists everywhere, but at our hospital, at Hasbro Children's Hospital in Rhode Island, we have
Mhm.
a center. It's called the Aubin Center, AUBIN.
Mm.
It's made of professionals who are, most of them, I think, are pediatricians who are trained in child protection. So sometimes we consult them and they can come, and they are the mediators between us and the child protection services of the state, especially if we're dealing with a case where it's pretty complicated, and they can help us with it.
That's great. But I think what you've given here are just beautiful nuggets, invaluable information. So the biggest thing from me is just to tease out what the intention is, where this is coming from. Is there perhaps a secondary gain that is coming with it from the parent's perspective that might help you? So trying to focus on those things might be able to help you. And then, I love the fact that, as you're saying, get somebody else to weigh in. Perhaps we're using our own filters to make the judgment and evaluation here. Love, love, love this conversation. Thank you so much. I could talk to you forever, and there's so much that we can be talking about. And perhaps we will again. For right now, what message would you like the audience of this podcast, this episode, to get from our conversation today, if you were to leave them with one or a few key messages?
I think the biggest message would be that I believe in recovery from all psychiatric illnesses. I mean, the others we can talk more about, but the chronic pain, personality disorders, functional neurological disorder, all the cases or patients that do not have hope, or people feel like this is something that people have to live with forever. I believe that people do not have to live with forever, whether it's depression, anxiety, all of it. People do not have to live with it forever. People think that I will have to accommodate and maybe live my life, but live with it. I believe that you don't have to live with it. These are illnesses that can be cured, and there's treatment for them. So that's my message.
Great. Well, thank you so much for taking the time. And I love your message that these can be cured, not just managed. And so working on those diligently and consistently, constantly, and keeping that belief is the most wonderful message that I can hear, my audience can hear. So thank you so much for taking the time. This has been such a lovely conversation.
Same here. I really enjoyed it. Thanks for having me.
And safe travels to you as you go on your travels. And so I really, really appreciate you taking the time. It was great. Thank you. There you have it, friends. This brings us to the end of this episode. And did I not tell you that this was going to be really rich and fantastic, full of great information, practical tools and tips that you can use in your practice right away? I hope through this episode, we have been able to give you some additional tools to better evaluate the coexistence of mental health and pain issues. Not only just to evaluate, but also to better manage them, to involve patients and families, to have a more holistic approach to it, as well as where we need to place our focus. And if you've been listening to this podcast long enough, you know that the theme here is focusing on regaining function, which is paramount, as opposed to focusing on the pain itself or the reduction in number, but rather to focus on regaining or maintaining function. And she, in this episode, talks about both for physical function as well as the mental health function. And my very, very favorite concept was that the goal is not to over-label, but to give them tools to move forward. And last but definitely not least is her message to all of us, that message of hope, of belief and of leading these patients to a much more positive place of that we can cure. We don't have to settle for less. Now it's your turn. I would love to know what you found most helpful and most interesting and engaging in this episode. I know it was a pretty rich episode, but if you were to pick something, I would love to know that. So please drop me your thoughts in the comments. I would love to hear those. In addition, I would love for you to let us know if there are particular topics that you would want to hear more around. As I said, I'm bringing you several incredible episodes in the next few weeks. I am super duper excited to bring those to you, and I hope you are just as excited to listen to them and to join us here. You will have brand new episodes. The very next one is going to be around physical rehabilitation and physical therapy and its role and how to engage these patients and how to help explain why physical therapy is so paramount in treatment of chronic pain. Then we have a more cutting edge research from two incredible researchers who talk about the new directions on the horizon, about predicting pain, about the patterns of use of medication, who might respond to certain things, and whether there is feasibility of some objective diagnostic criteria around pain. So I'm so excited to bring those to you in the future and several others. So stay tuned, join me every week. Until then, be productive, be proactive. Bye now. Pediatric Pain Focus is brought to you by Proactive Pain Solutions, a company committed to improving the lives of children affected by pain and the clinicians taking care of these children. Our mission is to ensure access to high-quality expert pain care for every child through innovation and in partnership with our empowered stakeholders, which is healthcare institutions, clinicians, and patients and families. Through our online education and consultation for clinicians and institutions, we're creating experts and leaders in the field, empowering patients and caregivers with the knowledge and tools for self-management, enabling them to live a functional life. If you wish to advance your pain care expertise, improve the operational performance of your pain care services, or you just want your patients and families to be more informed and active partners in their own care, please contact us at www.proactivepainsolutions.com.